Dear colleagues, friends, professors from all over the world. My name is Ahmed Assaf. It's pleasure to co-moderate this session with my dear friend Ashraf Armia. This session is the sixth day of web meeting of the Watany Eye Hospital Summit 2020. This session is dedicated for the cataract and refractive surgery.
The title is Ophthalmology Debatable Situation.
And it's our pleasure now to co-moderate this session with Dr. Ashraf Armia from Egypt.
It's our pleasure to have our prestigious panelists.
Professor Dr. Fathi Fawzi from Egypt.
Professor Dr. Abdullah Hassouna and Professor Dr. Rami Riyad from Egypt.
Our esteemed guest international speakers include
Siri Ganesh from India.
Omid Kermani from Germany.
Shiraz Daya from UK.
Aliou Del Barrio from Spain.
Maria Romero
from USA, and Vladimir Piver from Slovenia.
Kathleen McCappy from USA.
And finally, Sergio Canarava from Brazil.
So now I am introducing the talk of my dear Professor Dr. Ahmed Assaf to present a very short G&G. Please, Assaf.
Okay. I think you can see my screen right now. I'm going to give a small talk about the new generation of monofocal IOLs. As you know, that the cataract surgery is one of the most common surgeries worldwide, and it's estimated that 4.5 million cataract procedure has been performed in Europe in 2016. Nowadays, the demand of cataract surgery is not only blurred vision, but the vision or deterioration of vision that compromise the daily activity or the hobbies of the individual. So the new trend now is for early presentation of cataract surgery, and nowadays the quantitative measurement of the visual acuity or improvement of the visual acuity to 2020 does not reflect the improvement of the patient's quality of life. And now we have clinical evidence suggests that the visual acuity is poorly correlated with the patient's functional vision after cataract surgery. So many patients may have 20/20 vision with or without glasses, but they are not happy by the visual outcomes. Sometimes they say that the eye cannot read anymore after the cataract surgery, although the patient was able to read without glasses before cataract surgery because of the induced myopia, for example. So the traditional monofocal lens may not provide the required functional vision in modern life, and this may reduce the patient's quality of life. We have been introduced with several multifocal lenses, and we have now the latest generations of the trifocal lenses, and they prove to provide a decent functional vision for distance, intermediate, and near. However, still they are subjected to some energy loss because of the diffractive optics, and we have some of the energy loss. This reflects to reduce contrast sensitivity, and of course, these lenses are still subjected to nighttime halos and glare. And now we have the EDOF lens, extended depth of focus lenses, which represent a sweet spot between the monofocal lenses in one side and the multifocal or trifocal lenses in the other side, to provide some functional vision for at intermediate distance, still not too much compromise of the quality of vision. However, these patients still reporting some visual dysphotopsias with the diffractive optics of EDOF lenses. We now have refractive EDOF lenses in the market, but they are under examination. However, we have proven now we have the diffractive optics lenses that although provide some functional vision at intermediate distance, but there are still some reports about the nighttime dysphotopsias and halos. So the new concept nowadays, or the new strategy, is to implant a monofocal lens with a little bit of extended depth of focus. And this extended depth of focus can be achieved by gradual increase of the power of the IOL from periphery toward the center. And the change in the power of the IOL is very subtle, so it does not reflect in the increase of the thickness of the lens in the central part, and even it cannot be distinguished by the naked eye appearance between the traditional aspheric monofocal lens and the higher aspheric or higher order aberration aspheric, let's say, monofocal lens, or the new generation monofocal lenses. And these lenses are not a zonal lens. Now we have the eye-enhanced lens of J&J, and this lens can be categorized as a high order aberration aspheric monofocal lenses. And this lens, there is gradual increase in the power from the start from the periphery of the lens optic toward the center. It's not, there is no zones, there is no steps across the optical surface of these lenses compared to the other zonal refractive multifocal lenses. And the aim of these lenses is to improve the depth of focus compared to the monofocal lens, so to provide some functional distance, some functional vision at intermediate distance. And you can see that these lenses cannot be distinguished between the from the traditional aspheric lens. You can see both lenses. This is the Technis single piece lens and the Technis eye-enhanced lens. Almost they look identical by the naked eye appearance. And this lens is not categorized as an EDOF lens. It's a monofocal lens with extended depth of focus. And the surface profile, you can see here in this graph, the middle graph, the surface profile when compared with the sensor single piece lens and the Technis single piece lens and the Technis eye-enhanced lens, it looks almost identical to each other. But after fitting the best fit sphere and draw these abstraction lines, you can see, you can differentiate now between the profile surface between those three lenses. This is a flat surface or flat line. Denote that the surface of the sensor lens is spherical, and there's a small hump here in the central part with the Technis single piece lens denoting asphericity on the anterior surface of the lens. And this hump is maybe exaggerated a little bit more with the eye-enhanced lens, denoting the increase in the curvature in the central part of the optic of the lens. So this lens is very comparable to the single piece Technis lens, the same spherical aberration of minus 0.27 to compensate for the corneal positive spherical aberration, and almost the same defocus curve, although it has a more broad landing zone here in the intermediate range at the range of minus 1.5 diopters, so it enhanced the depth of focus compared to the Technis single piece lens. And there was some questions about the tolerance to centration. Lab studies showed that this lens very tolerable to decentration, comparable to the Technis single piece lens, although there is increase in the curvature in the anterior surface of the central part of the optic. And you can see in this video the lens, this video, you can see that the lens is almost the same. It's identical to the Technis single piece lens, the same injector, the same cartridge, the same technique of implantation, the same one size. There is no change in the technique whatsoever, and you can only differentiate between this lens and the other lenses by the code on the container or plastic container of the lens. And the initial results showed that the Technis lens and eye-enhanced lens showed very comparable distance visual acuity compared to the Technis single piece lens with enhanced intermediate vision with correction or without correction. And the contrast sensitivity here is very comparable to the Technis single piece lens. And you can see that the photic phenomena is very identical between both lenses. So the increase in the power in the central zone of the lens does not reflect to diminution of the contrast sensitivity or the nighttime halos and glare as with the other EDOF lenses based on the diffractive optics or other premium lenses, the trifocal or multifocal lenses. This is one of my patients have been in implanted with the eye-enhanced lens. You can see this is the OPD analysis, the wavefront analysis. The left part is the wavefront analysis of the total wavefront analysis of the eye, and the central part is the corneal wavefront higher order aberrations. And this is the right part of the graph is the internal aberrations caused by the lens. It's very interesting that you see that the total spherical aberration because of the lens is minus 0.27 microns, exactly as planned by the optics of the lens or the manufacturer. And you can see across the optic zone here that that's the most central part of the pupil here. The spherical aberration is exaggerated to minus 0.62. It's not minus 0.27, it's minus 0.62. So exaggerated spherical aberration. This is how they improve the depth of focus of these lenses. And then you can see that the spherical aberration, again, you can see this is a enlarged graph. You can see this is the spherical aberration across the pupil. It's average of 0.27, but the most central 2.5 millimeter is minus 0.62, and you can see here that the average here exactly as planned by the Technis lens of minus 0.27 to compensate for the corneal spherical aberration, the average of 0.27. And you can see here, this is the planned wavefront analysis of the lens, and this is actually what we see actually in the patient's eyes, almost identical. And this goes with the surface profile of the lens after removal of the best fit sphere, and you can see the subtraction line. This the most central part of the lens shows a little bit hump, denote increase in the curvature and increase, of course, in the spherical aberration of these lenses. And this is one of the patients implanted with the lens.
مثل النفس المنعش.
طب في سطر صغير تحتيه كمان هنا اهو.
كان يتبع بهدوء مشواره سماوي.
طب وده؟
على مجموعة من.
طب قرب كده حضرتك الورقة كده زغللت؟
لا كده مش واضحة.
كده مش واضحة. طب نبعد تاني. كده واضحة؟
شوية.
طب ابعد أكتر. كده واضحة أكتر.
هو تقريبا واضح.
تمام. تقدر تقول الخط الصغير ده ولا صعب؟ ده صعب شوية.
So the patient can read with one eye at around 50 or 60 centimeters. He should extend his arm, and he can read around Jaeger 4 or 5, which is, I believe, it's very decent functional vision for such age group of patients. What about the contraindications of these lenses? Should we implant it, or should we have a selection criteria for these lenses as with the premium lenses at the trifocal lens or other EDOF lenses? No, you can treat these lenses as the traditional monofocal lens, so you can implant it in maculopathy, irregular corneas, astigmatism. Even if there is a ametropia, you can correct the residual ametropia with glasses, and still the patient can get benefits of the enhanced depth of focus of these lenses. So my conclusion that the future is bright, and the Technis eye-enhanced IOL is provide a revolutionary performance that defies the monofocal convention of the 2020 vision. Enhanced depth of focus could be achieved nowadays without photic phenomena, and new generation of the IOL's technology based on the aspheric higher order aberrations has been established. Thank you very much for your attention.
Thank you, Asif, for this very nice presentation about the new eye-enhanced our debate sessions. We're going to start this first debate between femto-LASIK, which Omid Kermani are going to take this side, and against the femto-SMILE that Seri Ganesh will going to debate Omid for this. So welcome, Omid, and can you share your presentation, please?
Yes, hello, Ashraf. It's very nice to be with you. Thank you very much for the kind invitation. And I really like to bash a little bit on SMILE, as you will see. Well, femto-LASIK versus SMILE, and I think we can all agree that there's more to a refractive error than sphere and cylinder. To my best knowledge, sphere and cylinder is the limit of what we can do with SMILE. And if we look at the progress that we have achieved with femto-LASIK in the past 10 or 15 years, there's a significant step towards customization and individualization. We can prevent the induction of spherical aberration. We can form the spherical aberration of the eye in such a way that the depth of focus can be increased. Actually, I myself have had a blended monovision LASIK, femto-LASIK on my eyes, and as you can see, I can perfectly read without glasses. So additionally, we can use topo-guided ablation profiles in order to correct higher order aberrations. And the FDA results of the latest Contura development show that we can go beyond perfect vision. Almost 35% of the patients could see better than 2012.5. And this is an FDA multi-center study result. So this is not fake. Now, laser tissue interaction matters when it comes to deal with higher order aberration. And you have to remember that the excimer laser is used as a resolution of 0.2 micrometer per ablation rate. And that's an order of magnitude less than what we can achieve with a femtosecond laser. Both lasers have their perfect indications and they do what we expect from them. But when it comes to higher order aberration and a submicron range of modification of the cornea, I think the excimer laser is just still the instrument to work with. Now, why not SMILE? I'm an early adopter, and I think when SMILE started, there was inflated expectations with regard to this new technology. And in the moment, we are in a trough of disillusionments. We'll see if this technology will come back or will come and take over kind of enlightenment and take a majority of the treatments. This is an open question yet. I think there's a lot in terms of technology that has to happen in order to achieve this. For the time being, I think the reason why I did not adopt to SMILE is, for example, the recovery after the procedure is slow as far as I can see in the literature, but also from the saying of the patients that I've met and also from colleagues who are working with SMILE. Now, what is the reason for this? Could it be that the flapless procedure is nice in terms of concept, but it causes some sort of mess in the cap because the cap doesn't really suit the bed anymore. And we observe that there are distinct micro distortions in the flap, and that could interfere with the clarity of the visual acuity. Now, it is said that SMILE is a safer procedure in terms of prevention of ectasia, and this is just not true. We have seen cases of ectasia. Actually, these cases, the first cases that were reported, they came from Egypt, nicely reported cases in the Journal of Refractive Surgery, Cataract and Refractive Surgery. And we all have to remember that the normal corneal topography comes up to 1 of 3 cases in ectasia. If you touch the cornea by ablation, then or by resection, you can just cause ectasia, and that's a fact, regardless of the procedure that we are working with. So, as a matter of fact, it is such that with regard to the consumption of tissue, we know that we have a higher tissue consumption for SMILE compared to LASIK for the same given ametropia. And additionally, SMILE is not a procedure that is free of complications. Actually, there are many complications that can happen. Epithelial ingrowth is just one example. Incomplete resection of the tissue is another example. And altogether, there's a very flat learning curve. And you have to do 100, 200, 300 cases in order to really be a professional and a good surgeon with regard to SMILE. So the question is, how many advantages does SMILE give to the surgeon that you encounter this price that you pay for it by complicating eyes that you can easily treat with PRK or LASIK? And finally, another weak point of the SMILE procedure is that the retreatment options are limited. You need to have an excimer laser anyway. You can do a flap cut on the cap, but then you have a very thick flap, or you can do a PRK on top. So in any way, you need to have an excimer laser. And And not to use the excimer laser for ablation just because you have SMILE, I think this is kind of irritating to me. So one argument that we very often hear is that LASIK causes dry eye and that SMILE does not cause dry eye as much, but this is myth. We all know that after 3 months, 6 months, patients who suffer from dry eye, they come back to normal. And if a patient had dry eye before the procedure, he will have dry eye after the procedure as well. That's quite normal, but that's the same with SMILE, I believe. So in summary, I think I do not see a single indication where SMILE could possibly perform better than femto-LASIK. And if I doubt to perform a femto-LASIK, I still have trans-epi-PRK and also there are phakic IOL. So if I still have doubt, I just don't do refractive surgery. So this is my position with regard to LASIK compared to femto-LASIK, to SMILE. Thank you very much.
Thank you, Omid. So we are going to see what Sari is going to debate you about. So I'm going to present his talk. I'm going to share his presentation.
Hello, I am Dr. Sri Ganesh, and I'll be speaking for SMILE in this debate. I'm a consultant for Carl Zeiss Meditech. Femto-LASIK has been the gold standard for refractive surgery, but has its share of complications. You can have flap-related complications. You can have loss of subepithelial plexus leading to dryness. The integrity of the corneal biomechanics is breached, and it's a relatively more time-consuming procedure because it involves 2 steps. And there can be minor patient discomfort for a few hours, about 5-6 hours after the procedure. There are many published papers on comparing SMILE and LASIK regarding the corneal biomechanics, dry eye, innervation, re-innervation, and also centration. And these have found that SMILE is a better option than LASIK. But let us leave that aside and look at my own experience from November 2012 to December 2019, where I've done more than 8,000 eyes, and 98.4% of them had 6/6 or better vision, and 68% better than 6/6 vision. So the refractive results were excellent, and no eye had complications like haze, deep lamellar keratitis, or infectious keratitis. Only 10 eyes required enhancement, 4 eyes with PRK, 1 with V-SMILE, 4 eyes with LASIK and Circle software. So the enhancement rate also is very low and the stability is very good. No eyes have safety is very well established. We also conducted a prospective randomized comparative study when we got the Visumax laser from November 2012 to May 2013 at a hospital. Patients were divided into 2 groups. Group A was femto-LASIK and Group B was Relax SMILE. This was an aberration-free LASIK. So looking at the efficacy, both SMILE and LASIK, the efficacy was quite good. 84% having 20/20 or better vision. The safety also was comparable, but the SMILE group had more gain in lines than the femto-LASIK group. If you look at the aberrations pre and at 3 months post-op, SMILE had lesser higher order aberrations compared to the femto-LASIK group. And if you look at the dry eye, evaporative dry eye with the T-BUT, then we found that SMILE scored over LASIK. We also checked tear osmolarity and found that with the SMILE group, there was a minimal difference pre and post, whereas with the femto-LASIK group, there was more post-op dry eye. Our results were published in the Journal of Refractive Surgery, and we concluded that the 3-month results demonstrated that refractive accuracy, dry eye, contrast, and induced aberrations were better for SMILE than with LASIK, and we mostly converted to doing SMILE procedures. We also did a study comparing the corneal flattening between Relax SMILE and femto-LASIK in relation to the optical zone by differential keratometry pre and 3 months. And we found that with the optical zone, SMILE had a significantly wider zone of flattening post-operatively versus the femto-LASIK. With the SMILE, we got almost 80% of flattening, and with femto-LASIK, it was 69%. So you have larger zones with SMILE, which give rise to better night vision and lesser spherical aberration. This is probably because of the there is no fluence projection loss with SMILE. And if you look at the literature on long-term results, and they are more coming out now, 5-year and 10-year results, Walter Second group, they found that the stability was very good and regression in the long term was just 0.48 diopters. When compared to femto-LASIK, this is quite low. If I look at my own revenue generation versus LASIK and SMILE and number of procedures per year, with femto-LASIK, if I started SMILE at 2012, with femto-LASIK, it had kind of stabilized at around 800 procedures per year. But after I started SMILE, you can see that the graph has been rising and the number of procedures per year have been increasing. And if you look at the revenue generation also, there is a whopping 70% increase in revenue generation after we have started SMILE. So patients definitely prefer SMILE, and day by day the number of procedures performed with SMILE world over are increasing. Because if you ask a patient which scar would you prefer, either a laparotomy or a laparoscopic scar, it's always the laparoscopic scar. They prefer micro-invasive surgery, and with SMILE also it is a minimally invasive surgery. You have a 2 millimeter incision compared to a femto-LASIK incision, which is 20 millimeters. My opponent may argue that there are some limitations of SMILE, expensive equipment and consumables, no automated cyclotorsion compensation. But we actually published a paper on manual cyclotortion compensation in the GRS, and we found that the results were excellent, as good as automated cyclotortion, and the results for silica were very good. Hyperopic correction not available at present, not commercially, but we participated in the global trial, and we found that for hyperopic correction with SMILE, the results are more stable than with LASIK. Mixed astigmatism cannot be treated right now with the commercial software, not, but we have treated cases of mixed astigmatism with the special software, and it works very well. Wavefront based procedure not available. You need wavefront based only for aberrated corneas. For regular corneas, you don't need it. And with SMILE, basically we have found that the corneal aberrations, induced aberrations, are less because of there is no fluence projection losses or cosine effect when compared to the examined laser. Enhancement can be only done with LASIK or PRK, and you lose the advantage if you do LASIK of a flapless procedure. But again, SMILE on SMILE is possible, and we have performed a couple of procedures, and there is literature also where others have performed this procedure. So with LASIK, you may be able to play golf after 48 hours, but with SMILE, you can even do contact sports like boxing. So definitely SMILE is a more stable procedure and with less restrictions, and patients are more comfortable after SMILE. And someday, most refractive surgeries will be SMILE. Thank you very much for your attention.
Thank you very much. I think Dr. Fathi, would you like to comment on both presentations?
Yes, please. And I'm very happy about the debate, because actually it gives us the extreme advantages and extreme disadvantages of each technique. And I'm definitely sure you will all agree they are both good and they both have their places. And to be a very, very fanatic to one technique against the other is like being fanatic to your own team and not to the national team. So I'm committed to the national team. I started my experience by the femto LASIK. I was quite excited about the results. I only started the femto SMILE when we got the machine at Watany Hospital around about 2 years ago. And I started slowly, and actually I'm quite happy about the results too. And I have each technique now has its place. Definitely when I have a small error and a high degree of cylinder, then customization then is extremely important. Definitely go for femto LASIK. But if I have a high error, let us say 6 diopters, minus 6 diopters or more, with no much of a cylinder, then I'm quite happy to do the film to smile rather than the film to LASIK. And I feel quite comfortable not having a flap in these high errors. Not all cases are suitable for phakic IOLs in high errors, because if you have an anterior chamber less than 2.8 millimeters of mercury, and then you're stuck, and definitely there is a good place for a smile. The recovery time definitely is much slower. We don't have the immediate wow effect we get with the film to LASIK. So you have to counsel the patient, tell him that you have to wait for a week or so until you get reasonable results. Even sometimes you might have to wait longer to get a perfect result. But definitely the smile patient, I really don't worry about his follow-up, even if he rubs his eye or goes to heavy sports. You occasionally get this kind of patients where they need to do quick swimming or heavy sports. Also ladies who have their wedding very soon and they don't want to have subconjunctival hemorrhage. Really the subconjunctival hemorrhage in the film to LASIK stays for quite some time. And sometimes I see patients 4 weeks after surgery and they have the disfiguring subconjunctival hemorrhage. I never get any with the smile. So to be a fan for one technique against the other, I don't think it's the best thing. You have to have a role for each of them. And thank you.
Thank you very much. How low myopia would you do for smile?
Well, you can do as low as -1 diopter, but I don't think this is the best thing. You have to increase the minimum thickness. You're actually removing too much tissue for no reason. So I don't normally do low errors in film to smile. And I don't really leave the patient to decide for himself. I discuss with him and persuade him what is better for the eye.
Okay, Ahmed, in 1 minute, would you like to comment?
Well, we are in a very nice situation when you are a surgeon and you work at a hospital, and your hospital manager offers you the option to work with any machine that is available on the market, and there's no bias whatsoever in choosing the procedure for your patients. If you're working in a private practice, as I am doing it, I'm afraid of the bias it can get catched into. And Sri Ganesh said it. It's an expensive machine. The PIs are very expensive. And as a private surgeon, when you have to pay for the machine, you definitely will fall into a bias with regard to which procedure is the best for your patients, because you have to pay back the machine. So you cannot put yourself free from this. And this is a trap I don't want to fall into. I have a wonderful machine with femto-LASIK PRK and phakic IOL. And I know if I would, in my private office, purchase now a smile machine with all the adapted costs and PIs, that I would have to promote it the way our colleague did it. I would have to promote it, I think, in not such a sober and open way. I would have to promote it in a way which I ethically cannot stand behind it. I don't see the advantages. The part that the procedure becomes more expensive, the patient has to pay more, and that is finally the commercial side of it. I don't want to talk about commercials, but in refractive surgery, we have to really take care that we don't fall into a bias trap, so to say, to promote a procedure that we are urged to follow because we have to pay back the bills. So of course, when I see that the numbers of smile increase in such a way as we see it in the movie or in the video, well, there's no way your bias is there. Even if the procedure are equally good, you will promote the more expensive one because you have to pay the bills. So I wait for the situation when smile will become a procedure with 2, 3, 4, 5 companies offering it, and when the prices are reasonable, and when I have a fair competition without promising people or causing kind of over expectations. So for the time being, I'm going to wait for another year or so until we have 2 or 3 machines on the market, and the prices will become more reasonable.
Okay, Thank you very much. You have got a good valid point. And now we're running out of time, so we'll shift now to the second topic of debate about the extended depth of focus lenses. I will call my colleague Ashraf Armia, who will talk about the extended depth of focus. Why does Ashraf like the extended depth of focus lenses? And then this will be followed by Shiraz Daya to counter act or the presentation of Ashraf Armia, why Shiraz doesn't like the extended depth of focus lens. Ashraf, it's all yours right now.
Thank you, Asif. I'm going to share my presentation. It's very difficult to debate Shiraz. He's a very good debater. I listened to him a lot in many meetings. He is very tough in debate. So I'm going to try to be slowly in this. So EDOF versus trifocal. I have no financial disclosure about my presentation regarding any of the brand I'm going to talk about. As you know that the cataract leading causes of vision impairment. So we are going to restore the vision. To restore the vision, now you are saying that it's a refractive procedure. And when you tell the patient this, that you're offering a spectacle independence. So I know that we are leading now to a multifocal IOLs. Leads to different foci, so there is either it's a refractive or diffractive option. So when the extended depth of focus, it's an advanced optical technology increasing the range of focus. So EDOF gives a clear vision ranging from far up to intermediate distance. But close object, as we know, say that we are going to need to wear a near reading glasses. So the most commonly used multifocal are bifocal ones before the coming the trifocal era. And the trifocal IOLs were thus subsequently introducing, offering third focal points above the bifocal lenses. So the EDOF technology is based on elongation of the distance of the eye remains in focus, thus aiming to provide uninterrupted range of vision. This table I'm going to highlight it now and at the end of my presentation. You have seen here the bifocal, trifocal EDOF. I'm going to debate on 5 points: the distant intermediate, the near, reading performance, the contrast safety, and the optical phenomena. Look at this, and we are going to see this table in the last. So these are the 5 points I'm going to debate on. The quality of intermediate and near. Trifocal lenses were developed in order to ameliorate the quality of intermediate vision. And several studies have investigated whether implantation of trifocal helped to promise or improve the intermediate vision compared to the EDOF IOLs. So according to the studies that done for the Panoptic, the Zeiss, the Atrelisa, they finally highlighted the importance of the luminosity in measuring the visual acuity with the bifocal or trifocal. International agreement of the luminosity settings and such visual acuity measurement can lead to inaccurate conclusion. So the newest advent in the IOL development of the EDOF also refer to extended range. So as we started by the thickness, which is approved by the FDA in America, after this we come a lot of FDAs. But then since then, numerous studies have been conducted comparing the EDOF lenses mainly to the trifocals as well as to the bifocal ones. And all the studies also said that it was, I said, in terms of visual outcome and the contrast safety. And investigators reported that the Miniwell EDOF IOL had similar uncorrected distant vision outcome to the previous studies using the multifocal IOLs. Very important point of photopic conditions. There was no statistically significant difference in the uncorrected intermediate vision outcome between the EDOF and the trifocal. And you should, I can admit that there is a superiority of the trifocal over the EDOF for the near vision. But both the EDOF and the trifocal achieve spectacle independence for intermediate and distance. And there is a higher usage of spectacle for EDOF for the near vision, not for the trifocal. But still the level of post-operative satisfaction was the same in both patient groups. What about the defocus curve? The bifocals have a very significant V-shaped defocus curve, as we are going to see. You can see the three defocus curves of the bifocal, trifocal, and the EDOF, and the only V-shape is the bifocal, but the trifocal and the EDOF is a lot of similar. And you can see in the deep focus scale show statistically significant better visual acuity in eyes implanted with the trifocal. And also the EDOF produces a smooth, uninterrupted and dome shape like the focus curve, which provide a good quality intermediate vision and tapers off at the reading distance. I should highlight also that the multifocal and the EDOF IOL's performance has also been shown to depend on the pupil size. The EDOF provide the best vision at 2 mm pupil size. The trifocal IOL shows better pupil independence than both bifocal and EDOF. This is a point with the trifocal. What about the contrast sensitivity? Another aspect of highly investigated, but you should know that there is a superiority of the EDOF over the trifocals in the term of contrast sensitivity due to the compensation of the chromatic and the spherical aberration of the EDOF design. It's also confirmed this hypothesis and demonstrated that the EDOF thickness symphony is associated with enhanced contrast sensitivity under both photopic and mesopic conditions. And also the EDOF and the bifocals are absolutely no statistical difference in the contrast sensitivity between the EDOF and the clear contrast safety deficiency in the trifocal IOLs. What about the reading performance? So reading performance, it's not easy to examine because this is a complex process. And thus the result of reading ability assessment should be interpreted with caution. Enhanced contrast safety of the EDOF lenses post-compensate for the worse near vision in this type, thus leading to similar reading performance. What about the optical phenomena? The optical phenomena based on the division of the light into different foci. This is the EDOF, but this is the multifocal or trifocal IOL. But the multifocal or EDOF implantation is the occurrence of undesired optical phenomena which may compromise the quality of vision. Evaluation of the optical phenomena varies across different studies, which make valid comparison of different IOLs is almost impossible to make. And also we must know that the frequency of all the aforementioned phenomena desired as the time goes, because likely due to the neuroadaptation. And when you comparison between the EDOF and the trifocal show no difference in this photopic phenomena, and less than 1% of the patient experience these symptoms. So the conclusion is either JEF or JIF. Over the last 10 years, newer IOL technology has revolutionized cataract surgery so that the rising the patient expectation of excellent distance, intermediate, and near vision. But the choice of IOL should depend on each patient needs after thought, questioning about their work and daily habits. The main IOL type that have been developed include bifocal, trifocal, and EDOF IOLs. And the EDOF lenses provide a better contrast sensitivity and decrease spectacle dependence for distant and intermediate vision. However, the EDOF lenses also, you must admit that it's inferior to trifocal for the near vision. So look again to the table. You can see that when we compare the distance, both are the same, but the intermediate, the EDOF is superior. For the near, the trifocal is superior. The reading performance, the same. The contrast safety, the EDOF is better than the trifocal, and the optical phenomena, they are the same. So my take-home message is, remember the critical importance of carefully selecting and matching your patient to the most appropriate IOL. Don't skip on chair time and make sure you choose the patient with appropriate psychological and clinical profile. Always remember, they should have healthy eyes, in particular healthy tear film and no dry eye syndrome, and negligible side effect, faster neuroadaptation, and true EDOF resulting in more satisfied patient. We should always, everyone should be happy, not just the patient, but also the surgeon too. Thank you so much.
Thank you very much, Ashraf. Now we'll shift to Shiraz. We'll talk about why Shiraz does not like EDOF lenses. Please, Shiraz.
Can you open your mic, please?
Okay, can you hear me? Can you see me?
Yes, okay.
Okay, Ashraf and also Ahmed, I hope we're still friends after this one.
I'm neutral.
You were speaking on behalf of hands. I get this term, hands, fancy names, really confused.
It's not an EDOF lens. I declare this.
What?
It's not an EDOF lens. It's a monofocal lens. So keep me aside. Keep me away from this debate.
Well, I am taking a contrarian view. Some of you have heard me give this talk before, and I've enhanced it a little bit. So I've enhanced my talk. I've into my talk. Anyway, I have a contrarian view. I work with a lot of industry. These are the individuals I've worked with over the last 2 years. And working with industry, I know, and I accept there are positions that we all take, but you know, that's only the tip of the iceberg. There are a huge amount of interest below all that. And we really need to look below the surface. Now, what do we all want for our patients? We all want the best, right? And there are so many out there. In 2010, 2011, there was one choice of lens, which was absolutely fantastic, which I chose to use. And I put in a lot of them, and I've had a very good experience. So there are these other ones that have come along, and everybody feels they got the best. Well, I want to make 2 points on EDOF. Firstly, I reckon it's bad terminology, and it's time we changed it. We are smart doctors. We're ophthalmologists. We're like the rock stars in medicine, and we use such garbage terminology to describe what we are. And it's actually influenced by industry, and shame on them, and shame on us for accepting it. And the second, my second point is, why even bother with EDOF? So it's not about rivalry, whether it's a Taycan you've got or a Tesla. I'm just switching over from a Tesla to a Taycan, by the way. I've enjoyed the Tesla, but it's time to move on. It's not about rivalry. It's about our role as doctors to reduce confusion to patients and also to our colleagues, our other ophthalmologists. We ultimately want to deliver what patients desire. So this is Dick Lindstrom's adage. When I was his fellow in 1991, he kept reminding me of this. He said, Shiraz, patient satisfaction equals outcome minus expectations. So don't raise expectations too much. Give them a phenomenal outcome and revel in that accomplishment. And that has rung true right through to this day, many, many years later, 28 years later. So the common misconceptions, and you've heard some of them today, based on all sorts of studies, not defining which kind of EDOF in inverted commas lenses we're talking about. They say you get great vision and no dysphotopsias. It's just not true. They say there's less chances of explantation. Again, not true. And there's this misbelief that every patient is going to get similar outcomes. Again, not true. This is a Daily Mail article on a particular lens that people are now falling out of love with. So there we go. Anyway, terminology, the EDOF has been borrowed from photography. It actually stands for not extended depth of focus, but extended depth of field. So what influences depth of field? Well, we know that when you zoom in, you shallow the depth of field. But in photography, when you reduce the aperture of your lens, you increase the depth of field. And that's really what it all stems from. So the correct lenses that should use and deserve to use the term EDOF are the IC8 from AcuFocus and the Extra Focus invented by Claudio Trinidad that's distributed by Mocha as an out-of lens. So this is what EDOF is, not all the other things that we discuss. So the terminology needs to change. And really what we're talking about is range of focus, increased range of focus and full range of focus. How about simplifying it? And then we can talk to patients sensibly, and we can talk to each other as colleagues as to what we're talking about. And then there's mechanism of action, which influences some of the unwanted symptoms that patients find. And there's a whole bunch of mechanisms of action, which I'm not going to go into. But I did a survey for ACOS, and we contacted all these companies that I could think of that provided all sorts of increased range of focus lenses and full range of focus lenses. And this is the list right here of full range of focuses, foci. I have to still define this, and my colleague David Shahnazar and myself are going to go through the objective literature to see who deserves to fit in which category and what criteria are we going to use to define a lens as full range of focus, whether or whether it should be increasing range of focus. And you can see the list of increased range of focus is increasing too. The only one that deserves the title, as I've already mentioned, of EDOF is AccuFocus and Extra Focus. So now, my point, why bother increased range of focus lenses? Now, I acknowledge there are a few special cases with corneas that had previous laser eye surgery, or got higher asphericity or more, or maybe formed for keratoconus, whatever. These are not the normal patients, and they require some intellect. And we have a bunch of panelists here that I have great respect for, that have this intellectual prowess. But generally, what do patients want? They want good vision. They want spectacle independence. They want maximal range of focus. Of course, they want limited dysphotopsias and adverse effects. But we're talking about these things like they're permanent and they're going to cause them big troubles. What are they willing to compromise? That's our job as doctors. So we need to get a thumbnail view of the patient. And there are many ways we can do this, from the Dell questionnaire to talking to the patients, finding out what they do for a living. Do they fill out their questionnaires in green ink? You know, these are the red flags that you look out for with patients. From an ophthalmologist perspective, our perspective, we want to provide patients with value reliably. If they're paying us for something, we want to make sure we give it to them. We're not going to give them a car with 3 wheels. We want to give them a car with 4 wheels. So what happens when the lens does not do what it should? Do you give them your money back? I'm not sure. I don't deal with these increased range of focus eye lenses, so I don't have to bother with that. You got to manage your expectations. It's easier, much easier, if you provide patients with a full range of focus. And you don't get these sort of disgruntled patients sitting in a waiting room, which are bad for business. So all of this is all about reducing photic phenomena. Let's face it, that's what we're talking about. That's the main motivator behind the lens, and it's perceived as a major issue. Let's be honest, it's really hard to measure this in advance. There's only one device, which is the SimVis, which simulates vision for different types of lenses, and I think it's really good for showing adaptation. But that can help to show patients what they might expect from a lens. But generally speaking, these are all subjective, and these are influenced by preoperative preparation counseling, management of expectations, getting patients to understand neuroadaptation and making sure that they are the ones who will neuroadapt. And then it's ultimately, yes, about patient choice and money too. That influences patient's choice. So the critical thing in terms of photic phenomenon is, can they drive? And I use a year as a yardstick. Are they able to drive at night at a year? So many lenses, as Ashraf's already described, get glare halos, and Ahmed did too with the eye hands. And even a monofocal lens causes halos and starbursts and other things. These are hard to classify because they're subjective. We can't objectively measure them. Patients can tell us about them and give us grief about them. Now, going on to what do? I use trifocal lenses. I have done since 2011. I've put in more than 8,000 lenses, and my practice is 95% premium. The only patients that don't get trifocal lenses are ones where there's a clear contraindication, macular degeneration, glaucoma, and so on. And I've used mainly fine vision. I've also used Zeiss trifocals, and more recently the Artis Symbiotes, which I think is a fantastic lens. And for those patients who are unfortunate to go elsewhere and get a monofocal lens, I've used the Cycloflex piggyback trifocal lens from Rayner, which is a good lens. And I also use it sometimes as a dual procedure with a monofocal from another company and the trifocal on top. In fact, I did 2 yesterday. How many have I explanted because patients had dysphotopsia? None. Did patients experience severe dysphotopsia? Yes, they did. 10% had difficulty in driving to begin with, but they're all driving now. Some of them still have some residual problems, but they're okay. They can read, they're pretty happy. And yes, okay, they have to drive slowly, but that's small beer compared to what they've got in terms of good vision. And there's only one patient that I've got that's not satisfied because everything's got, lampposts have got a little smear around them at distance. He's an engineer. And basically, he's got a capsulotomy. I've said to him, you're going to wind up with monofocal lenses, which will still give you the same phenomenon, and you won't be able to read. Do you want to take the risk? And he said, no, and he's walked away. So that's been my experience over almost 10 years. And if you take a sample of, this is a newer trifocal lens that we've been working with, and you take a look, binocular 81% are 20/20 or better. This is near vision, 69% are 20/20 or better. That's really small, you know, J5 and better. At 60 centimeters, 76 binocularly see 20/20 or better, and even better, at 80 centimeters, 95% see 20/20 or better. Contrast sensitivity is a point. Look, contrast sensitivity, does a patient come walking in saying, I have poor contrast, doctor? They don't. I've not seen it. And we've measured it. And this is contrast sensitivity using this lens system, and it's very, very good. These are mean defocus curves showing the new lenses that are trifocals. They don't have these dips in vision where there's a loss. They've got good all the way across. They can an object and there's no dips anywhere. So let's take a look at some of these sample outcomes of a full range of focus versus an increased range of focus. This is a recently introduced increased range of focus. This is data from the company itself. And if you take a look in particular, the 20/20 rate from this increased range of focus is only 61% compared to the others. So the trifocal I just described, 81% get 20/20 vision. And if you go further and you take a look at halos, well, look, the monofocals give you 22%, and with this particular lens, 26% get halos, 34% get starbursts, compared to 48% with a newer trifocal, and that gets better with time. So increased range of focus, also known as EDOF, provides greater intermediate. Yeah, it does, not bad, but take a look at the intermediate here. It's a fallacy. The intermediate 85.8% get 20/25 versus the trifocals, which are better at intermediate. So what are we giving patients? What are you selling them? Are you treating yourself as doctors, or are we treating patients? So for me, patient satisfaction, I'm going to back to the Lindstrom comment. We need to understand we're looking for good patient satisfaction, and we need to give them what they expect. They expect to be able to read. So in a nutshell, I believe increased range of focus lenses are not reliable because they're based on corneal optics, axis length, and neuroadaptation, and it varies from patient to patient. They want good, crisp near vision, definitely at near. The circle of confusion with increased range of focus is not crisp, which is why they don't see 20/20, and they still generate photic phenomena. And so I believe the industry and ophthalmologists are a bit disingenuous when describing all these to patients. It is not forgiving. I've taken out several of them, and it's okay as an entry point for the dabbling surgeon who wants to get into refractive cataract surgery. So I would say increased range of focus is probably for the dabblers and the sissies out there. Well, there you go. No satisfaction. Thank you.
Thank you very much. Dr. Abdullah Hassuna, would you like to comment? I think you work on
thank Ashraf and Dr. Shiraz for their presentation. And I find still that the extended depth of focus lens have a place in our practice, especially post-refractive cataract, astigmatism, diopter, a little bit less, a little bit more, mildly irregular cornea, patients with driving by night but insisting on having a multifocal or correcting all the range of vision. This is shown here in the company that had the trifocal lenses. Now they are having a new type of lenses, which they blended the extended depth of focus with the trifocal. So I think if the companies have pushed for the extended depth of focus, blending it with the trifocal, so still there is a place in the extended depth of focus lens. But on the other hand, when you use an extended depth of focus lens, you have to treat two things. You have to treat the bad near vision, and you have to treat the dysphotopsia, which I agreed with Shiraz, it is still there in the extended depth of focus. But when you use the trifocal lens, it is only the halos and glare and dysphotopsia that you have to convince the patient that they will disappear. So for most of the patients, I think the trifocal will do good, but still we cannot deny that the extended depth of focus lens has a small role in our practice, and that is why that companies like Physiol and companies like Alcon has blended an extended depth of focus lens with the trifocal lens. So I think still we need this extended depth of focus technology.
So can I comment on that? I work for all of these companies, not for Alcon, but I work for many of the others. And let me tell you, it's a me too philosophy. because one company came out with EDOF, and they did really well in the United States where they had not much of a choice. They all decided to go on the bandwagon and try and use this as a segue for doctors to start to do refractive lenses. But really, it's a me too. And as time will tell, there are a lot of orphans out there. Yes, it's okay for the dabblers, but it's not okay for the expert refractive surgeon who's very good at accounting patients, evaluating corneal optics. So when it comes to LASIK patients, I put trifocals on all of them, and I've done over 400 of them now. Amazing. I've got to put that data together and put that paper together. I've already given a preliminary presentation on it at one of Ashraf's meetings, and it's quite outstanding in terms of how they do. And would you believe, you'd expect people with myopic LASIK to do better. Actually, it's the hyperopic LASIK patients that do better with trifocals than myopic LASIK patients. They both do really well. As long as the corneal optics are okay, no asymmetric aberrations, they do just fine.
I agree with Shiraz. I've tried them with post-refractive surgeon cases, and they're doing very well. I agree.
Thank you.
How can you use it with a negative asphericity that the hyperopic LASIK will give us a lens with a negative spherical aberration? So you add the spherical aberration.
It's nonsense, because when you measure spherical aberration, you're measuring at 6 millimeters. The average pupil size in a pseudofake is 4 millimeters. We measured it. So it has no relevance whatsoever. And we thought the same. So we're using aspheric lenses that are trifocal in hyperopes with high negative asphericity, and they have a better outcome than the myopic LASIK patients. So search me. And when I was scratching my head trying to figure this one out, and I realized it's actually due with pupil size. They don't walk around with 6 millimeter pupils, they walk around with 4 millimeter pupils. So in a practical world, they do better. So the gurus that talk about asphericity and giving them spherical aberration lenses, I'm sorry, but in my view, they're completely wrong. So I don't listen to the gurus. I look at the science and look at the results. Ashraf, you're very quiet.
What about What about the RK corneas? Do you put a trifocal, or are you going to use a EDOF in these lenses?
EDOF, the true EDOF, acufocus or extra focus. I use them. That's what I use in these patients.
So in post RKs, you prefer EDOF than trifocal.
Yeah, and I've used them, and I put them in bilaterally.
Yes,
and they're a superb option for these patients. They just love.
And what about using EDOF bilateral, and you do slight myopic shift, 0.5, to take the best for the near vision?
You mean with the IC8? No,
with the normal EDOF.
No, look, I don't use those lenses. They're terrible. They don't get patients with one.
I'm convinced with EDOF. Focus.
Aperture lens.
Focus are the EDOF.
Okay.
You hear what I just had to say, Ashraf?
So this should be the end of the EDOF lens.
Ask me to give you my opinion. I'm giving my opinion.
Thank you, Shiraz, so much. Thank you so much. Thank you so much.
Can I make
Sure, Maria. Ashraf, prepare for the next topic. Sure, Maria, please comment.
Okay, so I work with both. I'm in Baltimore, Maryland. Hi. Very interesting both topics. I use both lenses, because I don't think there is one lens that will fit everyone, because there are like multiple factors. And I've been doing this, intensely for 5 years. Here in the US, we are a little behind than you guys. That's why it's so interesting for me, because I know it's where I'm going and I learned so much. But on my experience, I have to explant for, what I call like unwanted visual phenomena, both EDOF and multifocal. Okay, very rare, and unfortunately, I'm going to say this, usually are females, and very rarely. And usually they do well with one eye and they're unhappy with the other. Very rare, but I have to explant some. And in terms of what I noticed in the complaints, and each patient, each population is different. Americans are different and they have high expectations, and it's like a lot of like a time screen. And I think that plays a role as well. And the patient won't come to the office and say, I don't have contrast sensitivity, but they will come to the office and say, my vision is blurry. And you measure the visual acuity, and they have the 20/20 and the 20/25, and they see near, you know, and I try to ask them what activities you can do, yet you feel like the vision is blurry. And I think that's where the contrast sensitivity comes to play a role. Patient won't come and say, you know, but they say, my vision is blurry, and you check the visual acuity, and you show them that they're 20/20, 20/25, and you just show them the near chart. But kind of you have to kind of convince them that they're seeing well, but it's not what they're feeling, no?
Okay. Great, Maria. Yes, great explanation. But we have to go now to two elegant, as I see, two elegant speakers. The first one is, as he wants always to see his Pario to be different than his great father. Jorge Alo, they are going to debate in front of my friend Professor Ahmed Assef about the monofocal versus premium IOLs post-refractive surgery. So the first debate will be by Jorge. Please, Jorge.
Thank you, Ashraf and Ahmed. It's a pleasure to be sharing this night for us with you. So my debate, basically, I'm going to defend the monofocal lenses, although I am going to really give you my point of view, okay? It's not black, as everything is never black or white, there's always a gray in between. So the question is, monofocal or multifocal in such patients where we are facing cataract surgery after a previous corneal refractive surgery. So it's a question of common sense, because this is the optical quality of the iris, the ocular quality with a diffractive intraocular lens, okay? And if we have this optical quality generated by a trifocal lens, a diffractive lens, and we add it to this topography with a patient with this cornea, what we can expect? So we can expect a mess, okay? This is very obvious, no? And this is just common sense, because we should remember that multifocal lenses distribute the light energy asymmetrically among different points, and this has a subsequently negative effect on the image quality and on contrast sensitivity, okay? So basically, this is an example of the iris, the ocular quality of vision with a refractive lens, the oculentis +3, and a diffractive lens, okay? We see that the quality of vision is slightly reduced. Of course, if we do this on a normal cornea, okay, this negative impact is going to be something that we can afford, okay? But the problem is when we're facing an abnormal cornea or a treated cornea, okay? Because we have to consider that multifocal lenses reduce quality, contrast sensitivity, and the quality of vision, okay, but also aberrations, corneal aberrations do. And corneal refractive surgery induces corneal aberrations. Those are higher as deeper is the ablation, okay? And of course, if we have a patient with a small optical zones or any complication, such as decentration, the aberrations are going to be even worse, the aberrations are going to be higher, and then the decrease in contrast sensitivity and image quality and quality of vision is going to be even further, even higher, okay? So, and this is the quality of vision, the ocular image, the ocular PSF of the patient of the previous topography. So if we have this image quality provided by the cornea, and we add to this eye a diffractive lens, so we're going to expect a disaster. We can expect it. This is very obvious. This is just common sense. So the addition of a multifocal IOL to an optical system with significant corneal aberrations can carry serious risks of leaving unacceptable quality of vision and even net loss of lines of corrected distance visual acuity. So we have to be very careful. But anything is black or white, as I told you. Is corneal refractive surgery an absolute contraindication for multifocal IOLs? Of course, it is not, because it's not the same. This topography that I have just shown you of a -9 microcraton LASIK from 1997 from my father, compared to this myopic -2 femto LASIK from last year did by me. The topography is not the same, the aberrations are not the same, and so the recommendation cannot be the same. So, monofocal or multifocal? It is critical. The answer is not give yes or no. It's just you should individualize each case according to the amount of corneal aberrations that will depend on the date of the original refractive surgery procedure, the level of treated ametropia, the original optical zone and any complication that might have happened, like decentrations, folds, haze, etc. But this decision will not depend only on the amount of corneal aberrations, okay? Because the image, the quality of the image quality will depend, it depends not only on the cornea, but also in the retina. So if you have any macular disease, because we should remember that many of these patients will be myopic, and high myopia is connected and relates to macular problems, macular disease, staphylomas, and all these problems as well will reduce contrast sensitivity, will reduce quality of image. The macular tilt also influences the outcome. So you should base this decision on the amount of the corneal aberrations and the back of the eye, that are the two things that are gonna influence on the image quality. And also, it's well reported that the outcomes after in patients with previous hyperopic ablations are usually worse than those with previous myopic ablation. So it's not the same, and we should also make the difference if the patient had a previous myopic ablation or a previous hyperopic ablation. And the last consideration that we have to, that we need to understand is that the spherical aberration is true that decreases the contrast sensitivity and ocular image quality, but also increases depth of focus, as we have seen in the previous talks. And by a mechanism of pseudo-accommodation, the patient can improve this, the spherical aberration can increase the near intermediate visual acuity. What that means, that some of these patients, even with a monofocal lens or a low adhesion multifocal lens, these patients can achieve satisfactory near visual function with just a simpler IOL. So, and with less risks of a higher decrease of sensitivity and photic phenomena. What that means, that if you're not sure, we should remember that we have a Hippocratic oath that says, first, do not harm. So if you're not sure, go to the safest option, because even with the safest option, multifocal low adhesion multifocal lens, these patients, because of the spherical aberration, may achieve satisfactory near distance and intermediate distance visual acuity. So what about the evidence, or know what we know about the outcomes after implanting multifocal lenses in patients with previous myopic corneal refractive surgery? There is some, it's not very wide, this evidence, but there is some. But as you have seen, as you're going to see, the outcomes are not the same as compared to those patients who receive the lenses with virgin corneas, because the risk of losing lines of corrected distance visual acuity is higher, and the predictability of the refractive outcome is higher, with a tendency towards the undercorrection. So not very wide evidence, although there is some. Okay, but regarding previous hyperopic ablations, the evidence is almost nothing. There is a very, very scanty evidence where the risk of losing lines is even higher and the predictability of the refractive outcome is even worse. So, previous myopic ablation, what says the evidence? But that you might achieve acceptable levels of safety, efficacy, and predictability, but you should have taken into account that your results will be worse than compared to virgin corneas, with higher risk of losing lines and worse predictability, and so high rate of enhancement, of laser enhancement after surgery. And with a previous hyperopic ablation, these results are going to be even worse than compared with a previous myopic ablation. The evidence is almost nothing, and we should take into account that the little evidence that there is used in patients with limited hyperopic ablations of +2, +3, is not the real patient of +4, +5, even +6 that the Swinamaris, for example, can provide. And last but not least, when we have to do a laser enhancement, of a patient after cataract surgery, it has been proven that the outcomes that you get are better if the patient has a monofocal rather than a multifocal. And this lack of predictability, if a patient has a multifocal lens with a laser enhancement, if it's even worse, if the patient is hyperopic. And we should take this into account. So what I do, because it's not black or white, it's gray. So if I'm facing a patient like this, with a mild higher order aberration, elevation, so a mild elevation of the higher order aberrations with a well-centered ablation, I go for trifocals. I fully agree with Serge Daya. I'm not a fan at all with EDOF lenses. And if I can, I go for a trifocal. In this case, of course, I go with a trifocal. The topography is normal. I can go ahead. If I'm facing a patient with a moderate elevation of the higher order aberrations, okay, either myopic or previous hyperopic ablation, I go for a refractive low addition multifocal lens. In my case, I usually search for a refractive sonular refractive lens like the Oculentis 1.5, because in these patients, I'm having a very good outcome regarding the near and intermediate vision. I don't promise them that they will be spectacle independence for near, but they usually, many times they achieve that outcome, because in between this low addition and the spherical aberration, they achieve good levels of near distance of visual acuity, and they don't have photic phenomena, because the Oculentis 1.5, if you have tried, is almost like a monofocal lens in this scenario. And of course, if I'm facing a very high and severe elevation of the higher order aberration with an irregular cornea, this is a pathological cornea, and you should go to the simplest option, just monofocal lens. Of course, if you have a high increase of the spherical aberration, then an aspheric lens. And always remember to the patient that there is a high risk of requiring a laser enhancement, and the patient should understand and should accept that this is part of the process that they might need. So if you're thinking about choosing a multifocal lens on a patient with a previous refractive surgery, what you have to do is to stop, to think, to individualize each case, and then if you're not sure, be conservative, because first, do no harm. Thank you.
Thank you, Elio. It's very, very informative presentation for a debate. I think you made it hard for Asif. So, Asif, how you are going to debate Jorge for this?
Actually, it's very easy, because almost we share the same concept. There is no black or white in this matter, either to implant a monofocal lens or multifocal lens. So Jorge highlighted it very clearly, and I, unfortunately or fortunately, I do agree with most of his talk. So anyhow, this is my talk here, and I don't have any financial interest, unfortunately, in this in any subject mentioned in this presentation. So as you know that with cataract surgery, the LASIK is the most common surgical procedure worldwide, and almost about 40 million LASIK procedures has been performed since 1991. And in the United States, between the 2000 and 2007, 1 million LASIK procedures has been performed. And these patients, when they are grown up and become presbyopia, they will look for another refractive solution. And when these patients will become a cataractus patients, they will ask for another refractive solution. These patients expect the same refractive results after cataract surgery. So they'll ask for another refractive solution similar to what they enjoyed after LASIK. So the issue with the previous laser vision correction, when the patient is getting older, these patients are very sensitive to induced cataract, and because of the added lenticular abrasions to the corneal abrasions induced at the time of the laser vision correction will significantly compromise the visual quality. They will ask surgery at early age compared to the normal or the other senile patients group of cataract patients. And these patients have high expectation. They are passionate for spectacle independence. And as I mentioned, these expect the same refractive results they enjoyed after a cornea refractive surgery. So as we know that the multifocal lenses have been successfully implanted in clinical practice, and they provide some good or decent functional vision and intermediate and distance, especially the trifocal, the new generation of the trifocal lenses. However, one of the contraindications of these lenses is the previous corneal laser vision correction surgery. So why it's relatively contraindicated? Because mainly because of two main issues. One is the biometry, related to the biometry, which is the most important issue, because it's quite difficult sometimes to estimate the correct IOL power. And the other issues related here are that's why it's contraindicated, because of the induced abrasion, as Jorge has mentioned in his talk. The induced corneal abrasion will significantly affect the visual quality after implantation of these premium lenses inside the eye. So regards the first issue, how we can calculate the power of the IOL, now we have several formulas dedicated for eyes with post-laser vision correction surgery trying to estimate the correct IOL power, and these formulas can be accessed through the ACRS calculator. And we have 3 modules, one module for previous myopic laser PRK, and the other for previous hyperopic laser PRK, and the other 3rd module for eyes after RK. And this website provides a general average of the IOL power, and it's good for general surgeon who cannot choose the correct formulas for his or her patients. This website has been subjected to recent revision to exclude methods that requires the pre-laser vision correction keratometry, because it's proved now in the literature and in the research that the no history methods or no history formulas are more accurate compared to the history formulas that requires the pre-laser keratometers readings. Now we have another new generation formulas, the Barrett-Rouquet formulas, which has 2 versions, and these formulas can be accessed again through a ACRS website or APACRS website, and it predicts the posterior corneal power based on the previous refraction before laser. And if you don't have this data or prove to be inaccurate, you still can use the Barrett-Rouquet formula with no history method, and it's provided this formula proved to provide better accuracy for the IOL power calculation after laser vision correction. And when we compare the accuracy after previous myopic or previous hyperopic, we can see that it's not very accurate as with the virgin eyes, but it's pretty close to what we get with the virgin eyes, especially if the myopia is less than 6 diopters. If the laser vision correction corrected only myopia of 6 diopters or less, and the same applies with the hyperopia. If we treated the eye with hyperopia of in the range between 2 or 3 diopters, we still can get accurate results regards the biometry or calculation of the IOL power. And now we have a new devices to measure the posterior corneal surface for better accuracy, and not estimation, but measurement of the total effective corneal power for better accuracy or better calculation of the effective lens position and the power of the cornea of the IOL after laser vision correction. So we have now what's known as the total keratometry, based on measurement of the posterior corneal surface by now new devices, new biometers, supplied with OCT, anterior segment OCT, to measure the corneal thickness and measure the posterior corneal surface. We now have another generation of the Barrett-Rouquet formulas that can take the measurement of the posterior corneal surface to be incorporated inside the formula for better accuracy to hit emmetropia after laser vision correction. And that's why we can get better results now with the calculation of the IOL powers, so we can reconsider again the premium lenses or the multifocal lenses from the biometric point of view. And as you can see, the Barrett-Rouquet with measured posterior corneal power results in less prediction error compared to the Barrett-Rouquet with the estimated corneal power and the other formulas in the ACRS website. So what about the aberration issues? Jorge mentioned that the aberration of the cornea is contraindication for implantation of the multifocal or premium IOLs, and I totally agree with him. But we now have a modern ablation profile, as he mentioned in his talk. You can see in this patient, this is one of my patients after myopic laser vision correction. You can see the spherical aberration is not induced very much. It's 0.39 microns. And you can see here that the coma and trefoil are almost in the normal range. So why not to consider implantation of multifocal lenses in this eye? So we can have the accuracy of IOL power calculation and almost the cornea like the virgin corneas with very small amount of induced spherical aberration, and the other aberrations like the coma and trefoil are within the normal range. Of course, we cannot consider eyes with decentered ablation like the one you can see in the right side, or the one with the small optic zone like the one you see in the left side. Of course, we have to exclude some eyes, or we have the powerful tools now to optimize the corneal surface before going to calculation of the power of the IOL and going through the cataract surgery. This is one example of my patients. Of course, this patient is not for premium lenses, but I want to show you how powerful tool we have with the topography guided PRK here. This is a case of corneal scar because of the previous ruptured globe. You can see in the middle, this is the pre-op after just before laser vision correction, and the left side, this is after laser vision correction. You can see the difference map. This, you can see the amount of astigmatism here. We can correct or change the astigmatism from the irregular astigmatism to more or less regular astigmatism, or more or less symmetrical both eye. So this to highlight how powerful tools we have now. We can optimize the corneal surface prior to cataract surgery and prior to calculation of the IOL power. And now we have different IOL optics. We have the EDOF lens, sorry Shiraz, we have the EDOF lens versus trifocal lenses, and EDOF lenses prove to be more tolerable for the induced spherical aberration or myopic ablation compared to the trifocal lenses in many of the literatures published. And of course, the EDOF lens proved to be more forgiving and more tolerable for the ametropia after laser vision correction compared to the trifocal lens. So we have new IOL technology, we have better technology to calculate the power of the IOL. We have now better laser technology to optimize the corneal surface and to induce less aberration on the corneal level. So why not to implant premium lenses after laser vision correction? And this is one of my cases. As you can see, this is, of course, as Jorge mentioned, that the amount of corneal aberration, if you can see the patient with some myopic flattening in the center here, of course, you can consider here implantation of premium lenses. This patient has been implanted with EDOF lens in the right eye. She was myopic because of the nuclear sclerosis. And you can see this is the accuracy, you know, the accuracy of the IOL power calculation. This is the post-op refraction after calculation, after implantation of the Triumph or the EDOF lens. Based on the diffractive optics. And you can see here the total corneal aberrations. It's almost within the normal range. This is the total spherical aberration. The total trefoil is a little bit towards the higher side. The total coma 0.369. It's a little bit above the normal or the accepted level, like the virgin corneas. And this patient enjoyed a decent quality of vision. Of course, the quality of vision is slightly lower compared to the virgin cornea, but the quality of vision of this patient was very satisfactory, and she was very satisfied with the visual outcome. So to implant the premium lens after laser vision correction, yes, if we have good ablation profile and good centration with large optic zoom, yes, if we have improved now biometric formula and devices to calculate the power of the posterior corneal astigmatism, we have now new IOL with improved optics, and we have the ability to, for possible post-operative laser touch-up. Of course, I won't consider these lenses if the ablation, previous laser ablation was too much myopic ablation, so the cornea outside the range of 3.6 to 47 diopters, or if there is a decentered ablation or small optic zone, of course, would induce higher corneal or abrasions, or if the patient is not accepting to go for laser touch-up before or after the premium IOL implantation. In these cases, of course, I won't consider premium lens. I will go for monofocal lens, possibly the aberration-free monofocal lenses. So my key message here that first, we should revise the phrase multifocal IOLs are contraindicated in eyes with laser vision correction, previous laser vision correction. The second point is the accurate biometry and the devices are available nowadays for accurate IOL calculation makes it possible to implant premium lenses. And the third point, new trifocal and EDOF lenses are promising and may be considered in some selected cases or some selected eyes post laser vision correction. Thank you very much.
Thank you, Asif, so much for this presentation. Dr. Abdullah.
Thank you, Ahmed. Thank you, Jorge, for your presentation. We cannot go blinding our eyes because we will be confronted with thousands of patients that has undergone LASIK surgery, and there will be coming in the next years seeking cataract extraction. And these patients has been all their life without glasses, and they will ask for us to get rid of their glasses, that they don't accept reading glasses or so. So we have to confront this. So if we confront this, there is some elaborate work, hard work to do before taking a decision, and this work will be a good history, and knowing the demands of these patients, knowing his personality. Then we have to do a topography and analyze this topography. And in our hospital, we calculate we look at the ISV, we look at the EKR chart at 4.5 millimeter, we look at the angle kappa, which is really an important issue. And then we have the biometry, the OCT one, and we use a good formulas for calculating. And then we decide, and most important is the surface of the eye, because those patients are all patients having glazing surgery before, so they have dry eye, and we know that the dry eye, those patients will have, if they have a multifocal lens or a trifocal lens, they will suffer a little bit if we do not treat properly their dry eye before the operation. And so if they meet the criteria of good topography and the values that we had set, and they have a good personality, we will go for this type of lenses, especially if they are myope. If they are hyperope, still, I'm sorry, Shiraz, I'm a little bit reluctant, because the patient with a hyperopic LASIK has a multifocal cornea already. He has a big angle kappa, and big angle kappa is more pronounced in hyperopic patients. So, and they have a negative Q value, as we discussed before, and the biometry of a hyperopic patient is more difficult and not that accurate as in myope LASIK. So why not putting a monofocal lens and do a little bit of monovision, because those patients has already, after their hyperopic LASIK, an extended depth of vision, so they can read already. So for me, for a hyperopic LASIK, I will put a monofocal with some monovision. If the patient had undergone a myopic LASIK and they meet the topography, good biometry, and a good surface of the eye, I will go for a trifocal lens.
Thank you very much, Dr. Abdallah, for the...
And I just a quick word in half a minute. It's actually, I would stress what Shiraz said, that we have to be careful using the terminology, because the terminology of virgin cornea does not always mean normal cornea. Sometimes you had a cornea that you had not been treated before, and it's not a normal cornea. And you do have the corneas that have been treated before, and they are still normal. So I would definitely treat the post-LASIK cases the way I treat normal eyes. So if the cornea is fit for LASIK, fit for trifocal, it's fit either has been treated before or not.
Thank you very much.
There's one thing that I just want to comment is that a lot of the comments that have been made are related to, they're extrapolated from laser eye surgery, like, for instance, angle kappa. I've got to say, I don't differentiate. And when you talk about angle kappa, it makes a difference when you're on the corneal surface, but not when you're near the nodal point, which is where the lens sits. So it's irrelevant. There may be a degree of decentration, but with 6 degrees, 6 diopters of angle kappa does not translate to 6 at the nodal point. So I think you're omitting patients where they could actually be suitable for vision correction using trifocal lenses. So I think that we need to be careful using laser eye surgery as the yardstick when we're doing trifocal lenticular surgery or refractive lens surgery. And that, I see that commentary being made over and over and over again, but without any real basic science or or evaluation in the practical world. So
There's a lot of literature citing that the angle kappa is very important when you implant a trifocal lens.
And I know, and I don't.
There's a lot of literature.
I know, and I don't buy it. I do it all the time, and I have not explanted any. I don't have patients with troubles.
Abdallah, be careful. Don't you still a judge? Don't be side in the debate.
Okay. Okay.
Thank you.
I'm talking science, you know.
Okay. Now, I'm just want to add one more comment. I totally agree with Shiraz. I have implanted a patient with hyperopic patients with normal cornea, not previous laser vision correction, with the large angle kappa, and the patient was insisting for a premium lens, and I was very reluctant to implant this lens in the patient, and the patient has angle kappa with a chord length of 0.6 between the pupil center and the corneal vertex, and the patient is extremely happy with no photic phenomena whatsoever. So it's very debatable, the points of angle kappa, because there is controversies if the importance of the angle kappa in the IOL or the implantation of the premium IOLs in patients, or the laser vision correction. Sometimes it matters, sometimes I don't. To be honest, I don't have a clear point of view right now, but I agree with Shiraz that maybe sometimes we can implant these patients with large angle kappa with premium lenses. So we must revise our selection criteria, I think so. Maybe we should move now for the next topic regards the complication or the challenging cases for IOL implantation. We have the Yamani technique versus the glued IOL technique. I would like to invite Vladimir from Slovenia to talk about the Yamani technique. He's one of the fans of the Yamani technique, and I totally agree with him to talk against, and then followed by Maria will talk about the glued IOL technique and other techniques for scleral fixation of the IOL. Please, Vladimir, it's all yours right now.
Thank you. I would like to thank for the invitation. And my talk is about the Yamana technique. This is, in my hands, the best technique for IOL implantation in eyes without capsular support or without adequate capsular support. So financial interest, none. This is a case, it's a young guy, 6 years old, with ectopic lens. And I've a little bit adapted the Yamana technique to the anterior segment surgeons. And I will describe these things that I did different. In every surgery, I do mark exactly where I'm going to put my needles and how I do the tunnel. And it is advisable to check if the haptic goes into the needle, because some of these needles are not very well done. It has happened to me that I could not dock into the eye. So I'm holding the eye, doing the tunnel with the 30 gauge needle. And in this case, you will see the case from grasping the haptic until the docking procedure. So it's unedited. I'm using a lens that has a very thick haptic, so it's difficult to put it into the thin-walled 30 gauge needle, but when it is in, it doesn't fall out. So you can be sure it won't fall out. So now we are taking a syringe out of the needle, and we are releasing the needle that was docked haptic in already. So it's lying freely here, and we are going through the same incision that the lens was implanted with the other haptic in, and we are orienting now the haptic and the needle in the way we will be able to dock it without the problem. And you can see it is really not very difficult if you get it in the right position. Then the both needles are pulled away simultaneously, and the flanges are done on one side, and the same is done on the other side. So usually about 2 to 3 millimeters of the haptic are put into the needle. We don't have to do more than this, and the flange is done. Then both haptics are pushed backwards into the sclera. I like to see some ends of the haptics at the end, and this is a perfect centration at the end of the surgery. And also later after the surgery, excellent visual acuity. And I like to see these haptics because if something happens, I'm able to reposition the lens, shorten the haptics or whatever. So this is still this guy. I'm showing this video. Sometimes we have fallen lens, and we can do Yamane technique also in the very small pupils. We just use the needle to extend the pupil, and we are able to implant the trifocal lens in a very small narrow pupils. This is a transconjunctival surgery. There is nearly no bleeding. What I do, I give a little bit of anesthesia here and here just subconjunctivally. Now another needle is being introduced and the haptic is again docked. And now by pulling the haptics simultaneously out of the tunnels, the lens jumps behind, the optic of the lens jumps behind the iris. And we really have to do this simultaneously in the same direction as the tunnel is. Now, when this haptic is out, we go on the other side and do the flange here. Now this haptic cannot not fall down into the tunnel anymore, so we do the same on the other side. We should have a dry surface here to be able to do a nice flange. And then the haptics are just pushed backwards, actually, and the surgery is done. We always give antibiotic intracameral at the end of the surgery. So this is the lens I'm using and the Stereomedics 30 gauge needles, and it works very good. This lens has spherically has no spheric aberration, not positive, not negative, and it has a round anterior edge, what I think is very important. These are some things that one should consider. Especially important, I think, is to be able to do both tunnels in the same way, in the same plane. I do bend one needle 45 degrees. In the needle that goes towards me on the right side, I bend 90 or 80 to 90 degrees. So in this way, I can avoid tilt for as much as possible. And what is also important, the markers. I don't think that the marker, which is the same big, doesn't fit to an white to white of 11.5 or white to white to 12 or 13.5. So what are the advantages of these techniques? It is minimally invasive. We don't have to sutures, we don't have to glue, and we do go through conjunctiva. So no suturing of conjunctiva. There is a very small incision, no induced astigmatism, and we just do two 30 gauge needle tunnels, the same as and we do the tunnels. So there is no hypotony, because in anti-VEGF, you know, there's very seldom the water comes out of the eye. And it can be done in the small pupil cases, and the rehabilitation is very quick. And also the surgery, if I have an aphakic eye, I'm able to do it in less than 10 minutes, very safely. So in conclusion, it has really changed the approach to the patients where there are no zonules or dislocated lenses or pediatric cataracts also, especially the ectopic lenses. Thank you very much.
Thank you very much, Vladimir. And now we'll shift to Maria to talk about her point of view regards the intrascleral fixation IOLs.
Yes. Okay. Of course, I was ready, and now hold on a second. Sorry. So meanwhile, Dr. Pfeiffer, I just want to congratulate you. It was a great presentation. And I was discussing with Ahmed and Ashraf before we came alive about a paper that was recently published in the ophthalmology. But okay, let me see. Are we ready? Yes. So I'm going to discuss the glue IOL technique I've been doing since 2016. So as we all know, there are multiple approaches for, for secondary IOL fixation in cases of absence of capsular support. But there is no really literature that will show the superiority of one approach compared to others. In terms of complications, visual acuity, or long-term side effects. Recently, the American Academy of Ophthalmology was published this article where they compare. And basically what they did compare was anterior chamber IOLs, open loop with clinical, scleral fixation. They didn't do like a Yamani or glue, but they compared with a scleral suture and suture into the iris. And they found that there was no statistical significant, benefits, one technique over the other. And I did some research last night to see if there was any recent publication about the Yamani technique in terms of long-term or comparing, with other techniques to see if they have any data. And there was one paper where they did compare the Yamani technique with the iris club. And they found that both were, have a good result, that there was no, advantage. So I was very, enthusiastic about the Yamani technique and the others approach when when it came out. But then, I started to receive all these pictures about, all these haptics that, immediately after the surgery or long term, that we see they are exposed or about to expose, like causing some kind of complications. And one of the questions for Dr. Pfeiffer at the end of the case, or Dr. Ahmed, how are we treating these like exposed, optic captures, if we're using a sclera or just, amniotic membrane, or just, like a graft of conjunctiva. So what I like about the glue IOL fixation technique, okay, let me facilitates the. So this is the glue IOL technique. It's a small animation. So after performing the scleral flaps, we use the haptics to fixate the lens into scleral tunnels that are designed parallel. What I like about this is with the handshake technique and with the, the ability to manipulate the haptics allow me to, calculate and, to have a good centrations of the implants. And then I'm going to share a case that I did, many years ago. This was one of my first glue IOL that I did here in the US. And it was a patient that has, many years ago, like 20 years ago, an iris suture IOL. The patient had pseudoexfoliation. He also had a trauma, ocular trauma. And so the iris, the lens dislocate. So after performing the scleral flaps, I delineate the tunnels with a 26 centimeter. I make sure that these scleral tunnels are like permeable with an iris spatula, because this is a critical step, and that's what I like to perform this technique over the other ones. First, because the scleral flaps even can be difficult to perform, to calculate the thicks, but they will protect the haptics. And I actually, even when I do a scleral suture, the suture, I like to use flaps to protect, any exposure over time. In this case, I have to flip and reposition the IOL with micro scissors and micro forceps. And then using the handshake technique that consists in the alternating grasping of the haptic until the very tip is reached. It's important to manipulate very gentle the haptics on these patients. So I do recommend to use, in my case, I like to use the lens from Johnson & Johnson or all AMO. It's like the 3-piece IOL, the CBB003 or size. This is an all lens and the haptics work fine. So when I'm going to externalize the haptic, I grab the very tip. So the haptic is not strangled in the sclerotomy. And I perform the same maneuver on the contralateral side. And another tip is to secure that haptic that is externalized to prevent that what I'm manipulating that haptic, the lens, is dislocated again. So I grab with my forceps one haptic before externalizing the second one. And this is what I think this technique is superior to others, because now I start to tackling the haptics into the scleral tunnels. So I just make sure that the scleral tunnels are open and permeable, and then I can use micro forceps or I can use the micro tires, and I just tackle the haptics into the scleral tunnel. And using the Purkinje dots from the microscope, it allows me to slowly maneuverate and go one side and the other until the lens is properly centered and tilted, and I make sure that the lens is like safely. I always like to do a small vitrectomy in the place where the haptics were externalized to prevent any strand vitreous and also CME or any retinal detachment or retinal tear that is common on these patients. And then I use the glue that I use usually organic glue, first instilling the fibrin and then the thrombin is a question that is asked. And I use the glue for sealing the scleral flaps, the conjunctiva, and even the cornea. And patients, what I like also is the eyes are very quiet after the surgery, and I usually finish the cases. So I started following my own cases, So the first technique that I used to secondary was the iris suture. Then I moved to a scleral suture, and then to the glue IOL. So here we use the Scheinfeld imaging from my, the IOL master in my practice, and I'm comparing the tilting of the implant. So on the first images in the left is an IOL that is in the bag. So the second images there we observe that there is a very, very, very minimal tilt, and that's a glue IOL. All these cases are on my hands. Now, the picture on the right superiorly is an scleral suture, still with good results. And maybe because I was a young surgeon, the one below, the bottom right, we can see that there is tilt, and this is a case that it has an iris suture IOL. So, well, basically those are my tips, and I think we don't have an answer. When we have so many alternatives in terms of different techniques and we are so divided, I think we're still, looking for an answer, and I think we should also consider what is the best in our hands. But I would like to, hear from Dr. Pfeiffer what is his experience.
Thank you very much, Maria. May I ask first Rami, Dr. Rami, to comment, because Rami has experience in both techniques.
Okay, Rami, yes, sure.
Okay, so for me, both techniques come handy sometimes. I agree with Dr. Pfeiffer when he said it's a quick procedure with a very white eye post-operatively, but it has a very steep learning curve. And this, I mean, we have to, when you start doing the Yamani technique, there are a lot of small problems that if you don't take care of, you have a very, very bad outcome. And as the picture that you showed, Maria, you showed some pictures of haptics that are broken, some haptics that are very short, so that the lenses are a bit decentered. And all this is caused by the poor technique. So you need to, if you are gonna really start doing the Yamani technique, you need to really look at a lot of videos and then do it slowly, and then it will come. But in the beginning, especially, even the site where you put your incision, even the sites where you insert your needles, even the needles that you use, even the micro forceps that you use, all those things, if you don't pay attention to each and every single one of them, you would have a more difficult Yamani technique. Glued IOLs are forgiving then. That's why I agree with Maria that the technique for the glued IOL is a bit more forgiving. So if you just learn how to do the handshake and how to manipulate the haptic from a hand to another, that makes it almost easy and almost done very easily. But I think the Yamani technique is a much challenging technique, and it has a much steeper learning curve. Dr. Pfeiffer, what do you think?
Thank you. Great comment. I must say that I've started with Chariot's technique about 15 years ago, and I didn't do very well. And then later on, I went with him to his operating room. And for that time on, I was very happy with this technique. The biggest problem was the hypotony. And it was very good. The gluing was a very good idea. And then when Yamani came, I started with Yamani. And as you said, every detail is very important. Every movement of the hand is very important. So you have to understand everything in your head, think about it, and copy somebody who is doing this very well. I'm using 23 gauge and gripping forceps, and I hold it like this, you see, like this. My movement is like this. And sometimes even you don't move the haptic, you don't move the needle, you can go with the haptic into the needle, or vice versa. Hold the haptic and go in with the needle. And everything has to be exactly oriented. And there is every detail. If you take care about every detail, the technique is very straightforward and the learning curve is quick. But you have to copy somebody who is successful with this technique. Sorry.
Do you agree with me that even the angle of attack, I mean, when you hold the haptic and you're putting it inside the needle, there's a specific angle of attack. If you're too low, it doesn't go easily. And if you're too steep, it doesn't go easily. So even the angle of attacking where you want to introduce the haptic inside the needle is very tricky.
It is very important. And therefore, it's very good if you start doing this outside of the eye and train it. And when it's everything clear in your head, then you go into the eye and start doing it in the eye. Because it has to be aligned. Everything has to be exactly aligned. Then it goes very, very softly. And there are forgiving lenses and less forgiving lenses. My lens, the JJ lens, has very thick haptics.
That's the one we use. That's the sensor lens. That's the one we use.
Correctly, yeah.
I would like to make a comment, if possible. All these techniques, I always think that they are very fancy and very interesting, but artisan is so much easy. Very simple. So why we like to complicate our life with super complex techniques that requires vitrectomy, much more expensive because you have to put the vitrector, the trocars. Why not just an artisan? As far as you have a normal iris,
always available.
I don't agree with you because of the incision. The incision is 5.5 millimeters. And if you do,
but you can do a scleral incision and then no astigmatism through a scleral incision.
And it's not always available. You know, sometimes when in Argentina or when you're in Egypt,
no problem.
it's not always available.
We definitely don't have.
We should pass. Yes, we should pass to the last debate because the time is running. So we come to the last debate between two eminent innovative, the Sergio Canaprava from Brazil and Kathleen McApee from USA. They are going to talk about different ways of scleral fixation. Hi, Sergio. Hi, Kathy. So we are going to. I know that Sergio is in the middle of the clinic, but he's taking some time with us. So, Sergio, can you show us how the debate will go between you and Kathy?
I can fight with Katy. Katy is in TV show of United States. Did you know about it? I saw this Sunday in Brazil. So famous in United States.
Yeah, don't tell everybody my secrets.
No, your house. Oh, it's perfect. Let's go. I will start to share it. Armia, it's a pleasure to meet you. Only because you invite me, because in the middle of my day, our patient wait me here outside here, and let's go to talking. Okay. Today I'll discuss about the double-flanged Canabrava technique, and I need to defend my technique. Here my disclosure, and here, Katie, let's go. What's the double-flanged Canabrava technique? Okay, it's a simple 5060 polypropylene suture that you can use to fixate a CTS. Today I discuss about subluxated cataract. Okay, here animation about the technique. I use a simple 50 polypropylene suture and remove it from the eye, and I do the first flange with the CTS, and I put the CTS in the subluxated area and do a second flange, and then only this. Okay, let's go to discuss the steps. My steps will about this paper that I published in the JCRS, and my question: what have I changed? Not you changed. I changed these steps. First, the bag or the iris rook. After the CTR. Step 3, the hydroprolapse, the nucleus and fake emulsification, and only number 4, the fixate the bag with the double flange of the CTS. Then, when I start my career with subluxated cataract, I use a Cioni ring, and I fixate the Cioni ring first, and then I do the fake emulsification. Now, I do the other part. Okay, here I will show an example. Here a patient with a microspherophakia. In this patient, I do catalysis or Lensex in all patients, and it's a young patient. How is a young patient? I prefer to use iris rook, but in an old patient, I use macro rooks, and then I use a visco to create a space to insert the CTR first. Then I use a CTR, and I don't fixate the bag inside. I don't fixate the bag in this moment. I prefer to hydroprolapse this nucleus to the anterior chamber and phakic emulsification. Only locks 1 and 2. Okay, locks 3 or 4. I prefer do a intra and fixate, and I fixate the IOL in the sclera. Then, after to remove this crystalline, and then I remove only one iris rook, and then I procedure the double flanged technique. Observe here, I'm removing the iris rook in the one side, and observe, I create a space between iris and the complex CTR and bag, and a 26 gauge needle, and I will insert the 50 polypropylene suture inside the insulin needle, the 26 gauge needle, and then I remove it from this part so slowly, and it's important to create a tunnel, and I will do the first flange in the CTS of the first side, and I will insert the CTS in the first side of the subluxated crystalline, as you can see, and then I repeat the movement in the other side, and again remove it from the eye, and I will do the first flange for the second time, and insert this flange in the bag again, and then only with the two flanges I can adjust it in the best position, and you cut this 2 millimeters from the base, and I will do the second flange for the first side, again about 2 millimeters to cut it, and I will do the second flange in the second side, and then it's important to insert the flange inside the scleral tunnel, and the IOL in the back, behind the two eyelets of the CTS. And then here, the final aspect, you can see the flange inside the scleral tunnel. Here, the CTS, the two CTS and the IOL in the right position. Okay, here a second patient with a Marfan syndrome to show example for you that in all my patients, I do catalysis or phaco. Here, how is a Marfan syndrome? The zonal is better. I don't need to use here iris hook or a macrolux. I only did the hydroprolapse the nucleus to the anterior chamber, and then I remove the 50 polypropylene suture to the sclera. Here, I like to show this video because it's one of my first surgeries. And observe, the tunnel here is not good. Now, it's important to do a large tunnel like you do in Amani. Here, the first flange, the CTS again inside the bag, and observe how you can control it and put it in the right position. And then here, in the not 3 millimeters, 2 millimeters is an old video. And then again, insert the IOL in the bag, and here a post-operative of the patient, the IOL inside the flange inside the sclera. Advanced, let's go to defend my technique. It is stable. Observe this test that I simulate in this test a silicone like a sclera. Observe, the flange is not rotate. The price, why the Gore-Tex is $8 here in Brazil, the polypropylene is $3. I don't know the price of the Meslan, the Gore-Tex in other countries, but I think it's about $40 or $50. The price is so different. The resistance, the 50 polypropylene is 100 times more resistant and 10 times thicker than the 10-0 polypropylene suture that you use to fixate the C1 ring tube. Easy to adjustable. You can see in this video a large flange that is easy to back it again throughout the eye, cut here, and cut it again, reduce the size of the flange, okay? And after to reduce the size of the flange, a small one, you can introduce it inside the scleral tunnel. Then it's easy to adjust it. Okay, and to defend my technique, the first part, only the first time I published it in 2017 that I received a prize in ACIS, but in the last years, more than 5 and 6 surgeons published different techniques using this double flanged suture. Then is it. Thank you. Kate, don't attack me a lot, okay? I'm your friend.
Well,
thank you,
this
Sergey,
is
so much. It is a very informative presentation. Kathy.
yes. So, you know, it's going to be really hard to be too critical because I am a huge fan of using Prolene suture and the double flange technique, but I'm going to do my best to argue with you, which I don't want to do really. But here are all my financial disclosures, which don't really apply. You know, with mild zonulopathy, we all know that just a simple CTR is really all you need. And there are some improvements that have made this a bit easier. I really like this preloaded iJet that has a curve that's a little bit more acute in the leading part of the haptic or leading part of the CTR. So I think that's been a nice improvement. But really, most of the time, I don't think that that's the most atraumatic way to put a CTR in. And so using something to engage the eyelet, either a suture, and there will be a new CTR coming out that Tim Page is actually working on that will come with a suture already in it for guiding it. But I like to use just a Sinskey hook, and you can really make this super atraumatic and really doesn't put any additional pressure on. And I think my threshold for putting in a CTR in anything that looks even mildly loose is pretty low, because I would much rather not have to do a nice Prolene suture later, and I would rather have it nice and stable to begin with. So all of them now, I do this. Of course, you do need a third hand, so you have your assistant, you know, depressing the plunger in order to get the CTR in. Moderate zonulopathy, you know, there's different techniques. When I first started doing these cases, I would always use 9.0 Prolene, and you can see that in the upper right. And that can work, but we all know that 9.0 and 10.0 Prolene will degrade over time. That's not really a great long-term solution, especially for patients with Marfans. They tend to be younger patients or like trauma, as you can see in this patient here in the lower image. And so Gore-Tex is a much better solution than using Prolene. It will last at least 9.0 or 10.0 Prolene. It will last the lifetime of the patient. It is off-label in the US anyway, so it is something that you need to disclose to the patient. But I don't ever hesitate to use Gore-Tex, and that's a really nice solution. You can see there's lots of papers that have been written on how not long-standing 9.0 and 10.0 Prolene are. This is actually Soonfik Shi's video. She's just an amazing surgeon. So when you have a bigger zonulopathy, just like Sergio was also showing, you want to use a CTR plus suture maybe 2 segments in. One might not be enough. But if you have a whole CTR and you have 2 segments, that's a very stable long-term situation. And so that'll last. That's not a problem. And now I'm just going to jump on the bandwagon with Sergio. So here goes. After me saying, well, maybe there's this other solution with Gore-Tex, this is really what I like to do. So if we have a case where there is, you can see it's actually a severe anterior capsular phimosis, but this is a patient who had a CTR. So again, I'm really happy to put a CTR in at the time of the surgery. I'm glad this patient had a CTR, even though they also have an AO60. So they have these closed loop haptics. And I'm going to do just what you said, Sergio. So there goes the whole debate, because I'm going to go ahead and also do this 5.0 Prolene suture with a 27 gauge needle. I just guess the only thing I would say that I've changed with that is I'd like to use 6.0 Prolene now with the thin wall 30 gauge TSK needle that we use for the Yamani technique. I just think that that's a little bit easier to use a very small flange and bury the flange. And I have a little bit less worry that maybe that'll erode over time. I don't really think it's a big worry, but there are patients who are just chronic eye rubbers. And I think the more you have a small flange and it's really in the sclera, the better that is. And so, you know, I think that I'm a huge fan. I'm on the bandwagon for for double flange and larger gauge Prolene. So if you wanted to see a bloodbath, Ashraf, I'm sorry that I could not comply because actually I'm just also a fan of that technique. So preoperative planning, just make sure you have multiple options, even when it comes to scleral fixation, plan A, B, C, however many it takes. Practice those techniques, review videos, have plenty of supplies with backups. Make sure the OR staff know what the plan is, review the plan with them, and then look and review your videos later so you can keep modifying and making things better, just like Sergio was also saying as well. And I want to thank you all for your attention. And again, so sorry that it's not a bloodbath between us.
Thank you, Kathy, so much. Thank you, Sergio. Dr. Fathi, what's your comments? Dr. Fathi, are you with us?
Yes, I am. Like you see, we have plenty of ways to fix the lens when you don't have enough capsular support. And definitely at the end of the day, that's the surgeon's preference, what you think is best in each situation. And like I was saying about the film to smile and film to LASIK, it's good to have more than one option, and you're not stuck in one option. And I would like to stress that Artisan is still a very valid option, and it can rescue many cases, especially when you are unexpected. Like when Kathy was saying, you have to be very well prepared, the staff is very well equipped, but when you are faced with a sudden situation during a surgery, then Artisan remains a very viable option.
Yeah, I'm very jealous because we do not have Artisan lenses here, and especially we don't have Artisan lenses that are appropriately powered for aphakia. So not an option.
Yeah, it does help, and especially if you're trained to insert them behind the iris, the retropupillary iris fixated lenses.
Seems like a beautiful solution.
And I've done quite hundreds of them, and I really don't have significant long-term problems with them.
Yeah.
Can I add a comment? I like to ask if your choice of technique is the same with progressive zonulosis, like in Marfan syndrome. It's the same if you have a traumatic zonular dehiscence, because a progressive one like the Marfan syndrome, you risk that even after putting a segment that there is a progressive weakness of the zonule, and after some years you will lose the zonule. So I like to hear the comment of Dr. Canabreva.
Yes, this is an important question. Last week, I have my first double flange technique with a Marfan syndrome after 2 years and a half that the flanges go down in the eye because, as you told, it's a progressive zone and it's a less collagen. And it was one of my first surgeries that I did a small tunnel. Then it's important to do a large tunnel to avoid this problem. Till now, in about 3 years in research, I have only one patient that, because this progressive zone, the flange goes inside, not because the polypropylene, because the polypropylene is so resistant, because the sclera is so thickener, but it's a point you need to explore more with the time. In patient trauma, I never have no problem with these patients because there's not a progressive zonulopathy.
Yeah, my only comment with that would just be that you have to look at the age of the patient, pretty much what you were saying, Sergio, too, and if it's going to be progressive. And I think even as much of a fan as I am of the larger gauge Prolene, that might be a place where I would prefer to use Gore-Tex.
Thank you.
I think no more questions. Sorry to we run out of time, and thank you very much. Thank you, Kathy. Thank you, Sergio, for such a great debate and videos. And it was a wonderful end of our session today. Thank you very much, and good night or good afternoon. Where are you?
Good night. Thank you for having me.
Thank you so much for everyone. Thank you.